It's got my great pleasure to introduce Susanna Pick, who many of you will know, has been at the IPPN as a psychologist working in the field of FND and has become one of the leading lights in this area, and has done lots of brilliant work in FND, particularly around emotion processing, but also worked on TMS for motor functional neurological disorders, and it's that topic today which we're going to hear about a trial which Susanna's published recently. So thank you so much, Susanna, for talking to us about this today.
Thank you. Okay. Thanks very much for tuning in, everyone. It's a pleasure to speak today about some of the work that we've been doing on TMS as a treatment for functional neurological symptoms. So just a brief overview. I'm going to start the talk with a bit of background regarding the rationale for using TMS in FND, and I'll summarise some of the previous literature in this area. I'll spend most of the talk on the TONICS feasibility trial before finishing off with a little bit on possible mechanisms of action and where I think this area of research might go next. As you probably know, FND is a complex and heterogeneous disorder at the interface of psychiatry and neurology. It's defined by neurological symptoms that aren't explained by known neuropathology, and FND has clinical symptoms that are incompatible with other neurological diagnoses. So the core symptoms are neurological in nature. They include weakness, movement disorders, seizures and sensory symptoms, but many patients with FND also present with a range of additional physical symptoms, commonly fatigue, pain and sleep problems, for example. In addition to that, psychological symptoms are common, so anxiety, anxiety, depression, dissociative phenomena. So it's a variable disorder. Patients present with often unique clusters of symptoms, and often the symptoms can change over time or in different circumstances, so they can vary in severity and in nature. We know that FND has a huge impact on patients and their families in terms of quality of life, restrictions on daily living activities, social and work impact. And it's also costly both for the patients and their families, but also for health and social care services. So it's an important disorder, and it's not uncommon. It's one of the most common disorders in neurology settings. So it's crucial that there are widely available and effective treatments for FND. So what are the options at the moment? At the moment, FND, so at minimum, an accurate and timely diagnosis, and along with educational resources is important. So there's been work to show that the diagnosis itself can be therapeutic if delivered in a validating, informative and timely manner. And of course, educational resources like the Neurosymptoms website can be really valuable to help patients self-education regarding the nature of the disorder. But in terms of structured treatments, the most common at the moment are CBT and physical therapy, and there is evidence or emerging evidence that these treatment modalities are valuable. So CBT particularly for people with functional or dissociative seizures, and physical therapy for people with functional motor symptoms. For patients who have slightly longer term problems or more severe symptoms, a multidisciplinary rehabilitation approach is often recommended, and this can be on an inpatient or outpatient basis, but it includes input from a range of disciplines, including psychiatry, psychology, physiotherapy, occupational therapy. But I think it's fair to say that at the moment these treatment options are not universally accessible for all patients with FND. There are quite a lot of barriers sometimes to accessing the treatments, particularly in terms of geographical location. And of course, there are often lengthy waiting lists. So there is quite a pressing need for the development of new treatments, which could be more readily accessible. And TMS has been proposed to be one such treatment. Transcranial magnetic stimulation, of course, it's a method by which to stimulate or modulate the activity of the brain. As I'm sure you probably know, it involves the use of an electromagnetic coil, which is placed above the scalp, above a region of brain that one seeks to target. And the coil releases a magnetic field impulses which can penetrate the skull and scalp and stimulate the neurons in the region of cortex underlying the coil. So the pulses of magnetic field can be delivered in single pulses, which are often separated by interstimulus interval in the order of seconds, or they can be delivered in high frequency trains of pulses, which is repetitive TMS. And the influence, the effect on the brain area underlying the coil can be either excitatory or inhibitory. So it can either facilitate the activity of that brain area, or it can dampen it, it can inhibit it. So TMS has been used for a wide variety of purposes, including cortical mapping, so effectively mapping what each part of the cortex does. Also measurement, excuse me, measurement of motor conduction speed, and more recently it's been used, repetitive TMS particularly has been used as a therapeutic tool in a range of clinical disorders. So just to summarise some of the disorders that TMS has been found to be efficacious in. This isn't an exhaustive list. I've just presented some of the disorders that the evidence is strongest for. But in psychiatry, repetitive TMS has been found to be valuable for major depression, post-traumatic stress disorder, and schizophrenia. And in neurology, several disorders are found to be responsive to repetitive TMS of different regions. So stimulation of M1, for example, primary motor cortex, has been found to be useful for neuropathic pain, complex regional pain syndrome, and several movement disorders, including Parkinson's disease and dystonia. Also, repetitive TMS of the posterior parietal cortex has been valuable for hemispatial neglect and focal stimulation in epilepsy. Tinnitus has also been found to be responsive to stimulation of the auditory cortex and temporal parietal cortex. So why do we think that TMS might be valuable in FND? So there are several reasons. TMS is known to be a safe treatment, and there are safety guidelines relating to potential risk of seizure induction. It's possible that it could be a widely accessible treatment that could be delivered in both inpatient and outpatient settings, and it's also thought to be cost effective. I think it's likely that it will be an acceptable treatment to many patients with FND, particularly because it targets brain-based mechanisms. And I think that in terms of the value, TMS could be useful in treating the core symptoms and their associated mechanisms in FND, but in addition, it could also be valuable for treating or for improving other additional symptoms such as pain and depression. So I'll just talk a little bit about the literature now, the previous literature. So a few years back now, Thomas Pollack conducted a systematic review of TMS studies in functional neurological disorder. And most of the studies were focusing on stimulation in the motor system for people with functional motor symptoms. They identified 10 studies, which included 95 participants, and 9 out of 10 of those studies reported improvements in the motor symptoms. But there were quite a few problems with the methodological rigour. There were no placebo-controlled studies, and outcome measures varied considerably between studies, which meant that it was difficult to effectively compare the results across studies. And the mechanism of action was unclear. Obviously, because there were no controlled studies, it was not possible really to rule out the likelihood that there was an expectancy or placebo response underlying the improvements. So there was a need for higher quality controlled studies. And since then, there have been a number of studies, or several studies, and I'll just summarise these for you briefly here. And again, these have all focused on stimulation of primary motor cortex, M1, in people with functional motor symptoms. So the first study, Broersma and colleagues, published in 2015, used a repetitive TMS protocol targeting M1 in people with 8 participants with functional paralysis. So they compared the RTMS to a sham TMS, and in sham TMS, effectively, it's all the same setup, the same procedures, except the coil just doesn't it doesn't release a magnetic field. So this was a single-blind study. The patients weren't aware of treatment and which treatment was which, and it was a crossover study, so the participants experienced both conditions. And the key results were that there was an objective increase in grip strength that was greater following the active TMS relative to the sham TMS. But there were no associated changes in subjective patient-rated symptoms. So whilst this was an encouraging finding, obviously the clinical value really depends on the patient being able to perceive the change. So the second study conducted by McWhirter and colleagues, published in 2016, also looked at TMS in people with functional weakness, with a crossover study also. But in this study, they compared single pulse TMS of M1 to treatment as usual. And this was, again, a crossover study. And interestingly, in this study, they found, and after the TMS session, there was an immediate improvement in subjective symptoms, but no objective improvement in grip strength or finger tapping frequency. And I think one of the important things to mention about this particular study was that the TMS was delivered above resting motor threshold. So what that means is that the TMS pulses induced an involuntary movement in the affected limb, so in the weak limb. And so it seems that potentially that induced movement could have been a key factor in the subjective change in symptoms. So Beatrice Garson and colleagues published another study in 2017. They used a repetitive TMS protocol, again focused on M1, in people with functional movement disorders in a larger sample size of 33. And they compared this to root magnetic stimulation. So both were delivered above motor threshold. So in both of these conditions, the stimulation resulted in induced movement. But of course, the key difference is that the TMS stimulation was cortical and the root stimulation was at the spinal level. So this was also a crossover study, and it was a single blind study. Their primary outcome measure was a clinician rated scale, and the clinician was blind to treatment, the treatment type. They found an overall improvement of 70% on the clinician rated scale, but no significant difference between the active, the cortical TMS and the root stimulation. There were patient-rated improvements though, and they persisted through to 6 and 12 months. So again, this study supported the idea that the induced movement when TMS is applied above motor threshold could be an active ingredient in this type of treatment. Finally, Tabe and colleagues in 2019 studied 17 people with functional tremor, and they also used a repetitive TMS protocol of M1. This was a parallel and double-blind study, so it was a high-quality, rigorous design. They compared the repetitive TMS to sham TMS. And they used a clinician-rated measure, which was the psychogenic movement disorder rating scale. And they found improvements in total movement disorder symptoms and also in tremor scores for the RTMS condition relative to the sham condition. But interestingly, they noticed subjective improvements in both groups, but no overall improvements in anxiety and depression. And this was the case in some of the other studies as well. So one question here is whether TMS can yield improvements in just the functional neurological symptoms or in the other important outcome domains as well. Okay, so I'll talk now about the TONICS trial. So the TONICS trial, I think, was really designed to test this hypothesis that the induction of movement in the affected limb is a key active component of this treatment. So it was a parallel double-blind design. So both the outcome rater, myself, and the patients were blind to treatment allocation. We looked at using single pulse TMS, 2 sessions, which were separated by 1 month, approximately 1 month. And it was targeted at M1, or the region of M1 that corresponded to the weakest limb, the person's weakest limb. So the two conditions, the active condition was single pulse TMS delivered above motor threshold, so that was 120% of a resting motor threshold, and compared to the control condition, which was exactly the same in every way except that it was below motor threshold, so it was 80%. So of course the active condition induced movement, the control condition there was no induced movement. In terms of methods, recruitment took place across King's Health Partners in London, and it included Guy's and St Thomas's, Bethlem, Maudsley and King's College Hospitals. We included people who had a DSM-5 confirmed diagnosis of functional limb weakness, confirmed by a consultant neurologist or neuropsychiatrist. We included people some of whom had more than one weak limb, and we targeted the treatment on the limb that the participant felt was the weakest or that resulted in most functional impairment. We only included adults and those with capacity to consent. Exclusion criteria were diagnosis of epilepsy or high risk of epilepsy or any other TMS contraindication. We also excluded any comorbid neurological diagnoses, major mental health disorders, factitious disorder, pain as the primary symptom, and previous experience of TMS or current enrolment in another trial. I apologise, I'm not quite sure why my slides are moving forward prematurely. Apologies for that. So outcome measures. The primary outcome was patient-rated subjective weakness, so it was the core FND symptom, and we used the Clinical Global Impression Improvement Scale, CGI-I, which is a measure that the patient rates relative to a baseline time point. So in this study, at each time point, they rated their current limb weakness relative to how it was when they entered the study. We also included a CGI-I clinician rating, so an outcome assessor rating, which I completed, and dynamometry as an objective measure. We also measured a range of other secondary outcome domains, including psychological functioning. So we included the core 10, the PHQ-9 and the GAD-7 to measure general psychological distress, anxiety and depression. We included the PHQ-15 to measure additional physical symptoms, the Work and Social Adjustment Scale, the Bartel Index to measure activities of daily living. Health-related quality of life was measured with the SF-36, and we also measured health and social care service use at each time point as well. So the outcome measures were taken, they were taken immediately prior to the first TMS session, and they were taken immediately, some of them were taken immediately after each session, and they were also taken at the 3-month follow-up point. Okay, so I'm now going to talk you through the key results, but before I do, I should just point out that all of the analyses conducted here, and the tables and figures that I'm about to show you were actually all completed by the trial statistician, Dr. John Hodsall. So I don't want to take credit for these, and he was blind to treatment allocation at the time of conducting the analyses. So just to talk you through the consort diagram on the right of the screen here, we were referred 32 patients who were potentially eligible, and of these 21 were confirmed as eligible at the screening. Of the 21 eligible participants, all accepted randomisation and all attended the first TMS session. These are encouraging findings. 5 participants didn't attend the second TMS session, 4 in the active group and 1 in the inactive group, and the reasons given were not related to the treatment itself. They were generally logistical issues such as work or being on holiday or other illnesses. But only 2 patients were actually lost to follow-up, and they were again lost to follow-up, 1 in each group, and they were lost to follow-up due to illness. So these are quite promising recruitment and retention rates. Blinding appeared to be successful. So at the exit of the trial, each patient was asked if they, they were asked to guess which treatment they'd received, whether it was the active or inactive treatment. And as the blind outcome rater, I also was asked to guess this, and neither the patients nor myself were able to guess at levels above chance. So that suggested that blinding hadn't been compromised. In terms of satisfaction, patients, we looked at how many patients were somewhat or very satisfied with the trial, and in the total sample, 76% said they were. The rates were slightly higher in the inactive group, so 91% of the inactive group and 60% of the active group said that they were satisfied. And reasons given for people who said that they were neither dissatisfied or satisfied largely talked about not having improved as much as they would have hoped to, or some unwanted side effects. But we did also receive quite a lot of positive feedback about the experience of the trial qualitatively. In terms of adverse events, there were 35 in the active group and 43 in the inactive group. So that suggests that the active suprathreshold stimulation didn't lead to more adverse events than the subthreshold treatment. Obviously, this looks like there were quite a lot, but the adverse events here, we classified these as including both events that were related to the treatment. So, for example, a bit of scalp discomfort or a headache, but also we included any new a physical symptom that occurred during the trial. So these were often symptoms that were unrelated to the treatment itself. Headaches, there were a proportion of patients in each group who reported headaches, 3 in the active group and 5 in the inactive group, but these were usually short term on the day of the appointment. And I followed up for anybody who reported a headache. I followed up within a few days to check whether they were feeling better, and they generally were. So patient demographics, the groups were well matched on most features. Age was similar, so late 30s, early 40s, sorry. Most participants in both groups were female, right-handed, married or cohabitating, and white or black British ethnicity. In terms of occupational status, unemployment or medical retirement was common, and this was often as a result of the FND symptoms themselves. Other background clinical characteristics, the participants had similar scores on a personality screen, the SAPAS-SR, and on estimated IQ scores, which was measured with the NART. There were some psychiatric comorbidities present in both groups, but in both groups, all of the participants were receiving additional treatments, most often medication. So medications included antidepressants, anti-epileptics, and analgesics most commonly. Some patients were also receiving additional treatments, which was most often physiotherapy on an outpatient basis. There were a couple of unexpected differences between the groups. So the duration since the diagnosis of FND was slightly longer in the inactive group, but the duration since the onset of FND symptoms was fairly similar. The other difference was that the inactive group reported more additional FND symptoms. So that was a slightly more complex, there were slightly more complex presentations. Obviously, in a larger study with a larger sample size, it would be possible to conduct statistical analyses to explore the influence of these unexpected differences. But in this study, because of the nature of a feasibility study in the small sample size, we weren't able to do that in the analysis here. So just looking at the primary outcomes, so this is the CGI-I patient ratings. If you look on the figure on the right-hand side of the screen, you can see to the far right, the response categories are just indicated there. So as I've said already, this scale runs from very much improved through to very much worse, with the midpoint being no change. And the primary analysis here looked at the proportion of participants in each group reporting being much improved or very much improved. And each of the panes here reflects a different time point. So if we look to the top of the figure, we're looking at the first TMS session immediately before the intervention. And here you can see that in the active group, there was none of the participants reported having been much improved or very much improved. Whereas in the inactive group, 9% reported that they were much improved. So there was some spontaneous improvement in the inactive group, but not in the active group. And this is before any treatment had taken place. So if you look at the panel below, that's the immediately post TMS, the first TMS session. So that's directly after the TMS had been applied, and the figures are exactly the same. So there was no immediate change in subjective symptoms after the first TMS session. Sorry. What you can see if you look down to the third panel there is that when the participants came back for the second TMS session a month later, there had been quite a marked change in the particularly in the active group. So the third panel down there, this is immediately prior to the second TMS session. So this is basically when they arrived at the second TMS session. And you can see there that now in the active group, 67% reported that they felt that their symptoms were much improved. And this is in contrast to 20% of the inactive group. So obviously there was an improvement in both groups, which you might expect. But the improvement was much more dramatic or marked in the active group. And looking now to beneath that, to the immediately after that second TMS session, you can see that the figures were unchanged. So again, the actual experience of TMS didn't alter the ratings in the short term. And then the final panel at the very bottom is the 3-month follow-up point. And here you can see that there's still a superiority for the active group. So at the follow-up, 44% of the active group reported being much improved compared to 20% in the inactive group. So these the effect sizes here were moderate at the second TMS session, and by 3 months they were small. But I think that these are encouraging data. And just to show you in the individual CGI-I ratings, so this is by participant, and obviously there's a caveat here. These, there are a small number of participants, and as you can see in these plots, there is some variability between patients, but there's certainly a pattern that is shared by some of the patients, whereby there is a very dramatic improvement between the first TMS session and the second TMS session, and that is improved. That is maintained to follow up. So particularly participants number 2, 3, 17 and 18 here, you can see that there's a very similar pattern. And these plots show both patient ratings and my ratings, and on several of these the ratings are very closely matched. So I think it would be interesting to look at these symptom trajectories when in a larger sample, and to explore whether that's consistent. Just for comparison purposes here, this is the inactive. These are the participants in the inactive group, and you can see here there's a much more variable response profile. There were a few patients here who improved between session 1 and session 2, but not to the same extent, and also those improvements don't seem to have been maintained in the same way. So the responses are much less clear in the inactive group, I think. So in terms of secondary outcomes, the results were much more variable and difficult to interpret due to small to moderate effect sizes, and also confidence intervals that at times included 0, so that it was difficult to be certain about the treatment response. But the trends suggested that the active group showed some possible benefit for the outcome rater CGI-I ratings. Core 10, so it's general psychological distress, the physical functioning, energy, vitality, energy, and role limitations subscales of the SF-36, activities of daily living, and also a reduction in primary care use. But there were a number of outcome measures that didn't seem to show any clear benefit, and these were dynamometry, the PHQ-9, so depression, the GAD-7, anxiety, PHQ-15, additional physical symptoms, and some of the SF-36 subscales, so bodily pain, social functioning and mental health didn't show any clear improvement in the active group. Or any clear superiority rather. Similarly, the work and social adjustment scale and inpatient admissions and outpatient contacts didn't also show a clear superiority in the active group. So I think it will be interesting to look at these additional outcomes with in a larger, more highly powered study. So a little bit about the mechanisms that could underlie the influence of TMS in FND. And these were highlighted by Thomas Pollack in the review I mentioned earlier. And I think the studies that have taken place since then give us a bit more information about which are most likely. So I think that in our study particularly, neuromodulation is unlikely to be the core mechanism. And this is because the protocol that we used was a single pulse, and single pulse TMS is not known, or it's not clear that it has a longer term neuromodulatory effect. So its influence or its effects seem to be short term at the time of the stimulation. Obviously, there are some studies that have used repetitive TMS, and it's possible that there was a neuromodulation effect there. But some of the studies used protocols that were unlikely to yield changes in the order of months. And in those studies, they often did see subjective changes, for example, that went up to a year. And it's questionable whether the neuromodulation would have that length of influence. So it's also possible that there's a motor retraining effect, particularly in protocols that have induced movement in the affected limb. So obviously people with significant limb weakness may not have moved that limb for a long time, or they may have only moved it minimally. And so by inducing a clear, albeit involuntary movement of the limb, it's possible that almost retrains the motor system, or there's a relearning of that normal function. And on a cognitive level, in light of explanatory models that emphasize the importance of beliefs and expectations about symptoms in FND, it's possible that the experience or observation of the movement of one's own limb could modify or weaken beliefs about the symptoms. So, for example, beliefs that the brain isn't sending motor commands to the limb, or that the limb is somehow damaged or not responding to the motor commands, by actually demonstrating that it's possible for I guess a normal movement to take place. Those beliefs and expectations can be challenged and potentially weakened. So obviously further research is needed to elucidate these mechanisms. But of course, really the mechanisms I've just talked about are specific to TMS4 of motor cortex in motor symptoms. I think there could be other mechanisms that could be targeted for other FND symptom types. Just a few strengths and limitations then. So the protocol that we used in the TONICS trial was a very minimal, what might be considered a minimal dose of TMS. And that, I think, has strengths because it will be less time consuming for the participants, fewer sessions to attend. And so it could be quite easily, it could be widely accessible and also acceptable from the patient's perspective. Obviously, there was a strength that we had a double-blind design and that the blinding was successful. And this was really due to the fact that the two conditions, the two treatment arms, were so similar. They were so similar in every way except the intensity of the stimulation. We also had a sample that was representative, we feel, of the broader FND population. So we tried to include individuals with additional symptoms and people who were receiving other treatments to make sure that we were recruiting a representative sample. In terms of limitations, obviously the incidental between group differences do present some challenges for interpretation. And this can be addressed in a larger study. During the intervention itself, the TMS sessions, we didn't use a formal script, And I think this could be valuable to standardise the way that the TMS is delivered, for example, to ensure that verbal suggestion is minimised. And in addition to this, as I mentioned, treatment adherence to session 2 was suboptimal. So for the next stage, it will be important to address that and to consider ways of improving adherence to the second treatment session. So the future directions for TONICS then, the next stage is a larger randomised control trial, which we're hoping will be underway later this year, now that COVID restrictions are starting to ease. So one of the changes, there'll be a couple of changes to the design. The protocol, the simulation protocol itself will remain the same, but the timing of the sessions is likely to change. So because of the marked improvement that was observed between the first TMS session and the second TMS session, it's likely that that could be amplified by bringing the second test session forward, so reducing the delay between the sessions. So that's one plan, and that will also help to minimise any kind of logistical reasons for non-attendance at the second session. And I think more in-depth PPI, patient and public involvement work would be really valuable in the next stage, and particularly to explore the potential mechanisms. So, for example, in-depth qualitative interviews could be used to explore patients' beliefs and expectations regarding their symptoms and the causes of the symptoms, and also their responses to the treatment and their perceptions of the treatment, just to kind of tap into those possible cognitive mechanisms that I've just mentioned. And also a more in-depth patient and public involvement work would be necessary to explore the potential barriers or impact of unwanted side effects, such as headaches. I think more broadly, TMS there's really a lot of potential for the use of TMS in FND, not just in motor symptoms, but in other subgroups as well. So, for example, it's possible that areas of sensory cortex could be targeted in those with particular sensory symptoms, or in people with functional seizures, for example. I'm aware of a case series recently that has used a repetitive TMS of the temporoparietal cortex with positive outcomes. So there are other cortical targets, and I think it's quite important to, given that many patients with FND experience a range of symptoms, a range of FND symptoms, I think it's important to identify cortical targets that might be relevant across the different symptom types. And I think the dorsolateral prefrontal cortex is one region that could be a really important target, given its roles in cognitive control, emotion regulation, and of course motor planning. So those are some thoughts for future directions. Of course, and planning future studies, I think there are some ethical issues to consider, particularly around the issue of whether or not suggestion is included in the stimulation sessions, and of course also regarding possible adverse events. So just to conclude, our study and some of the other studies I've summarised suggest that TMS to motor cortex is a potentially beneficial, safe, acceptable and non-invasive treatment for motor FND. It does seem to have the most prominent effects on the core FND motor symptoms. It's unclear at the moment whether or not there is a benefit for other outcome domains. But I think that there is also value of TMS for other FND subgroups, and I think this is an exciting area for future work. So just to say some thanks, this study was designed and funded by Dr. Tim Nicholson, who's the principal investigator. I've mentioned Dr. John Hodsall, who did the analyses, Professor Anthony David, who contributed to the design and conception of the study, and also to the neurophysiology team at King's College Hospital, led by Dr. Alistair Purvis, and the Dr. Viva Stanton and her neurology registrars at King's as well, for all the help with the clinical examinations. So thanks so much for listening, and I look forward to taking any questions.
Brilliant. Thank you, Susanna. Great tour through that study and the background for it. So do post any questions in the chat, or put your hand up if you have a question. And whilst we're waiting for other questions, just got a couple for you, Susanna. First one, I think it's more of a sort of we've become obviously quite interested in outcome measures for functional neurological disorder, and it's a complex disorder in many ways, FND, but the issue between subjective and objective measures and what our primary outcome measure should be. And I think it's nice that you've sort of reminded us of the sort of, I guess, a little bit of a signal perhaps, but I guess we have to be cautious over interpreting the data at the small numbers in all these trials of improvements in subjective but not objective. And I guess people could argue that that means it's less meaningful than objective. There's a general trend, particularly from funders, to insist on objective measures, and those are the more reliable. But I think there's quite a few issues which I think we've highlighted in some publications on outcome measures where perhaps subjective is actually more meaningful. And I just wondering if you could just draw you out to discuss those sorts of issues a bit about what your views are, having sort of got very stuck into outcome measures in FND.
Yeah, I mean, I think obviously in this trial we included an outcome rater assessment as well. So it wasn't pure, and the outcome rater CGI scores also followed a similar pattern and suggested a benefit. So yeah, I mean, I think a combination of both objective and subjective measures are important. But in the work of FND-COM that we've completed, the consensus really has been that the subjective patient-rated measures are most valid predominantly because, of course, the patient is aware of the variability. They can report on the variability in terms of severity. So if you take an objective measure at one snapshot, on a bad day, you might get a very different result to another point in time on that day, or the day after. So that I think the variability and severity, we can't necessarily see that with one-off objective measures, whereas of course the patient can report that to us. And I think also there's scope for measures including carers, so who often can observe differences or changes in outcomes that even the patient might not be aware of always themselves. If that answers the... Yeah,
that's great. And I think Sophie, I think I agree with all that. And I think I think that the interesting issue is about whether, because FND symptoms, the importance of subjectivity of symptoms over objective, I think, is as it's a sort of core part of the disorder. So we've got a question from Helen Ginadu, Star OT from the Lishman unit, who has raised a question. Thanks, Susanna, for a great talk. We had at least one patient from Lishman unit involved in this trial. We don't know which group they're in, but how would you tease out what may be made a difference in the TMS, the active or active MDT rehab for FND? So I guess there's a few things there, perhaps potentially about the role of other treatments, both in terms of synergistic effects, and also the issue, I guess, that you pointed out about balancing between the arms in a small trial, about what will because we can't really stratify for other treatment effects or withhold treatment ethically for people. So just wondering if you could discuss those issues.
Yeah, I mean, again, I think we are a bit limited interpretation due to the small sample size here. Obviously, it's a feasibility study focused on the feasibility parameters. But I think, yeah, certainly in a larger study, it would be good to ensure balance in terms of additional treatments. And I mean, potentially, there's an argument to exclude participants receiving, very intensive treatment, which obviously in an inpatient MDT setting, there's, intensive input on a daily basis. But I think also it's a question about, are we viewing this treatment as a standalone, treatment, or is it better to be viewed as maybe an adjunct? So something that might amplify the effects of other treatments. So it might complement, for example, what's going on in the MDT setting or in CBT or in physiotherapy. So I think we can't tease that out in this study, but I think we might be able to tease that out a bit more when we can do a more complex analyses with larger numbers. Or, as I said, I think there's an argument for excluding intensive inpatient treatments from the sample for that reason.
Yeah, I think it's really important issues, and I think the sort of complementarity or synergy with other modalities of treatment, I think particularly physiotherapy, I think, and I think Paul's on the line, but there's a patient that we, at the beginning of this research project, when we're getting the protocol set up, we treated a patient who'd been ill for a long time with very severe paralysis, and the main reason for treating was that there was not enough movement to be able to work within physiotherapy, so complete paralysis of both legs for over a decade, I think, if I remember, Paul. So I think that sort of and there was a sort of minimal change with the first session, and then things sort of the knot loosened perhaps with the second session. And I think the other thing that completely anecdotally with that patient, of course, was that we got one of the FND specialist physios to come along and do physio at the same time as the session, so you get the artificial movement induced by the TMS, and then with which the physiotherapist can immediately work and start to reinforce the sort of relearning of movement. So that felt like, I don't know if Paul, you'd agree that's a reasonable interpretation of that case, but that patient made a staggering recovery for someone who'd been sort of unable to move their legs for over a decade. So I think that's the sort of interesting, I think, next steps, if you'd agree, Susanna, for that type of issue. I think it's a critical issue that you've mentioned, Helen. So I don't know if you wanted to come in on any of that, Helen. Has that answered your question enough? Is there any other observations you've got, or any thoughts?
No, that kind of answers my question. I suppose what I was thinking was that if, you know, in a research where you're trying to prove that TMS is effective, it could be compromised by the fact that somebody is having intensive physio and other therapies. And I suppose it, you know, as a treatment itself, it sounds like it could be really useful. But I was just curious as to how you would establish that it was the TMS rather than the fact that people were having other therapies. So yeah, Susanna's answers has satisfied that. Thanks.
Yeah, I think most of the answers to questions with this are larger numbers and a bigger trial. And I guess then we can wash out those effects, but or at least sort of ensure that they're hopefully balanced across groups. But the other options, yeah. Sorry to.
Another way of looking at that is, of course, to look at the time course of the change. So when does the change occur? And of course, I think what we saw in the individual plots, and yes, that, you know, there are only a few, but I think what we saw that there was a clear and consistent, certainly among some of the patients, time course of the change. And I think that if that occurs in patients who aren't receiving those intensive treatments, then again that kind of suggests that it's the TMS, something about what's happening in the TMS that's leading to the change. So that's another way of looking at that. Yeah. Great.
So Irene, question from Irene Feynman. Thank you, Susanna, really interesting talk. I'm wondering if you're aware of any studies using combined TMS EEG in this area, or if you're planning to use EEG in your larger trial. It'd be interesting to examine EEG potentially as an objective outcome measure. So I was wondering, that's a very interesting question from Irene. So so I should have asked you, Irene, to say that rather than just reading it out. Sorry, but now that's occurred to me too late. But Susanna, if you wanted to.
I'm not aware of any studies that have combined the two. I believe that I think, Tim, you might have comments on the combination of using TMS with. I think you had some plans for other neurophysiological measurements. Is that in your next?
Yeah. I think that's more along the lines of seeing what's going on neurophysiologically before and after TMS, and I guess I don't know if you were. I mean, I guess that could be potentially. I mean, yes, we were just thinking about motor thresholds changing after treatment. So, but I think Irene's got more clever options. I don't know if you wanted to perhaps explain the thinking behind. Is this for some sort of signal of change of brain activation? I don't know, Irene, if you wanted to, because Irene's, I know, has done a big review of EEG and FND, and that's her particular area of expertise. And I think I'm not sure if your paper review is hopefully it's on its way to a journal and a publication site near you soon. But I don't know if Irene, if you wanted to.
Yeah, sure. Yeah, thank you, Tim. The paper has been accepted and will be out soon. I haven't done much work on TMS specifically, so I'm not really knowledgeable about TMS driven changes. However, I was just thinking that measuring EEG would kind of help elucidate a little bit the mechanisms underlying potential effects. And that would be obviously interesting to have as an information. Yeah.
Great.
As would functional imaging as well. Obviously, a slightly more expensive approach, but yeah, these are all exciting kind of ideas.
Great, and I just see Paul's got his hand up. Sorry, it's taken me a while to see the hands up, but I don't know if it was a separate question of if it was coming into the things that I mentioned for you earlier.
No, sorry, it is separate, and it's something I really don't know the answer to. You may have covered it already because I missed the start. But as I understand it, TMS can have both inhibitory and excitatory effects, depending on frequency, I think. But it's been a while since I looked into this. So, do you think there'd be a different approach for functional paresis versus hyperkinetic movement disorders, or is that something that's been considered already?
Yeah, so in the studies that have used repetitive TMS, so I think with RTMS frequencies below 1 Hertz and it tend to be inhibitory, and above, say 5, I think are excitatory. And so in the studies that have looked at, so there was one study, TABE, which they used an inhibitory protocol.
Okay, yes, I wondered that.
Yeah, and the other study was the Garsan study, and they used an inhibit. So no, they actually used. Sorry, I can't remember. It's slipped my mind the actual frequency, but I know they used repetitive TMS, but above motor threshold. So it was an interesting design. But yeah, I think that certainly, if you're expecting a neuromodulatory approach mechanism, then it would be important to, of course, use an inhibitory frequency with hyperkinetic and the converse.
Okay, thanks. Just out of interest, you mentioned a putative study in functional seizures. What would you use? Would you use inhibitory or excitatory, or
well, I mean, I mentioned that I think the dorsolateral prefrontal cortex would actually be. I think an excitatory RTMS protocol would be valuable in that group. Again, there's one case series that I'm aware of that have looked at temporoparietal cortex stimulation with RTMS, and again, I believe that was an excitatory protocol, but don't quote me on that. I can't quite remember. Yeah.
All right. Thanks.
Thanks, Paul. I think that's a really interesting question. Just because in case you know the answer, I don't. Susanna and someone else on the call might do. I know there's a couple of people with neurophysiology experts as well. But are there any? I guess I'm always slightly skeptical about neuromodulatory hypotheses in relation to TMS, depending obviously on what you're targeting and what disorder. But has anyone you aware, Susanna, of any models of either impairing dissociation or inducing dissociation through TMS protocols? I'm not so sure there's a from first principles there might be a sort of an easily modulatable dissociative network, but I'm just wondering if you're aware. I imagine people have tried, and if there's any literature on that and how robust it is, if that's something you're aware of.
I think I'm not aware of a significant literature on that. I think then there's some kind of arguments for temporoparietal cortex, perhaps, in terms of dissociation. But no, I can't really comment. I'm not sure that there's much on that.
And I think Nick Medford, just in case you happen to know off the top of your head, is anyone, just given that your particular area of interest. Anyway, in case Nick's got any thoughts on that, David, you've got your hand up.
Hi, Tim. Oh, thanks for a great talk. I really did enjoy it. Yeah, I was just saying that I've posted in the chat, but this idea of the value of CGI keeps coming up. And I don't know why. I think I posted in the chat that it's used in virtually all FDA approved sort of dynamical kinetic sort of trials in the States. And in addition to that, it's got an incredibly high kappa value when you measure its kilometrics in comparison to other, in relation to interrater reliability, for instance, and it correlates highly with, sort of the other measures of, whatever the primary outcome is for the trials done. So just to put this in context, the kappa values for CGI in many of the trials, so for example in schizophrenia, for instance, are in the realms of about 0.8, which is higher than or equal to the interrater reliability of two people reading a complex ECG or reading a complex X-ray, chest X-ray, for instance. I know, there is this sort of myth in psychiatry that because it's a psychological issue, it can't be measured in a way, in the way that, for example, blood, sort of some of the other more objective measures are. But the research doesn't really support that. So I hope you don't come to grief with, oh, you only use this as your primary outcome measure. I do think the broad scorecard of measures is important, but there's nothing wrong with that as a primary outcome measure.
Great, thank you. Oh, sorry.
And just underscoring that, the FND Com group that Tim and I were leading recently, developing recommendations for FND outcome measures. The CGI is the measure that we've recommended as a kind of primary symptom measure at the moment. For want of another measure for FND, that's at the moment what we agreed should really be the primary outcome, or one of the primary outcomes. So yeah, thank you for that.
And we've got some great qualitative data coming out soon from patients and stakeholders, which many of you might have contributed to from the professional's point of view. I think we're just coming up to the end of the hour, so I was just going to one question, just because of Susanna's particular expertise in modelling of etiology or mechanism of FND. That if you could, I think there are some potential changes with neuromodulatory devices, and TMS is very old technology that can really only target quite coarsely the sort of the superficial areas of cortex. But I think there's obviously ultrasound and a few other types of and if you could imagine some sort of Star Trek device to start targeting bits of the brain that you think might be aberrant in FND. I was wondering if you could just speculate on that as a final sort of and finally comment.
Well, I mean, obviously the first thing that people would say is, we would look at the limbic system. So, the amygdala would be an obvious target, given that in most of the neuroimaging studies that the alterations have been, that's one of the consistent findings. But as I say, I mean, using old-fashioned TMS, I think that the dorsolateral prefrontal cortex is a region that can that stimulation or modulation would potentially have a range of important benefits in terms of potentially, addressing attentional dysfunction, emotional regulation, motor planning. But also, in addition to that, we know that treatment stimulation of the dorsolateral prefrontal cortex can also help with things like depression, which of course many patients with FND also experience. So I think that would be my first suggestion. In terms of exciting new avenues and new technology, as I say, I think for me the obvious answer would be the limbic system. Yeah.
Great. I'll quickly wrap up because the builders have come back from their lunch break outside my window, so they can probably hear them. But thanks everyone for coming. Thanks Susanna for a brilliant talk. In 2 weeks' time, we've got Valerio Mondelli on inflammation and depression and immunopsychiatry more broadly. So I apologise for the background noise, and thank you again, Susanna, for a great talk, and to see you all. Hope to see you all in 2 weeks' time. Thanks. Bye.
Thanks,